Hello, everyone. Welcome to Hot Seats. I'm Omid Moghaddas. I'm from Tehran. And once again, so happy to be with you all from this educational platform, especially during these days that we have a chance to be more updated and learning from great practitioners from around the world is, I think, a great opportunity for all of us as dentists that we have a chance to learn and to go to the details sitting in our home and what can be better than that. And today I have a very special guest, a dear friend, Dr. Richard Martin from United States is here with us, a fantastic and super skilled oral maxillofacial surgeon. Hello, Richard. Welcome to Hot Seat. So grateful to have you with us now.
Hey, Omid, how are you?
Thank you so much for accepting.
Well, thank you for the invite greatly.
Thank you. Thank you. My pleasure. And you know, over the past sessions, we talked about different aspects in soft tissue management, in hard tissue management. We talked about prosthetic approaches. We talked about socket shield and so many factors, complications in the sinus, in bone grafting. But speaking of implant dentistry, usually the final touch, the final outcome is the satisfaction of the patient, which is very important for us. And definitely it's the soft tissue that defines the beauty of our procedure, the beauty of the results in implant dentistry that we gain. And the importance of shaping the tissue and soft tissue development is really something that many practitioners have problem with that. At least in my countries and in many countries, it needs skills. It's not just something that happens. We need to be able to shape the tissue the way that we want. Sometimes it takes more time, and we need to know how to do it predictably. So today's topic is one of the interesting topics in this field, I believe, which is the role of digital provisionalization in soft tissue development, which brings you another side of this story, not only learning how to shape the tissue, but also knowing how to do it even more reproducible and predictable with digital dentistry and digital solutions that we have in our hand available. So Dr. Richard Martin is going to cover this aspect very comprehensively for us, and at the end we will have a brief discussion together. And I have to say, before having Richard Martin's CV for all of you, I have to say that I had the chance and the honor to have him as one of the contributors of the first partial extraction therapy book in Farsi. I know you haven't received a copy yet, Richard, but I kept many for you. And this is the list of the authors. So you can see Richard here and his beautiful cases on primary teeth. I just wanted to show him the book from here, and then I will have many of these for you. I kept them, so after this COVID-19, when it's over and I have a chance to see you, definitely I will bring them for you. So let's go straight to our hot show. So first I will have Dr. Richard Martin's CV for all of you. Dr. Richard Martin originally is a native of Jamaica, as is an oral maxillofacial surgeon in Dallas, Texas, where he maintains a private practice. He's a graduate of New York University College of Dentistry, where he was elected as Omicron Kappa Epsilon. He completed his maxillofacial training at Harlem Hospital, Columbia University College of Physicians and Surgeons, followed by a fellowship in orthodontic and TMJ surgery at Oral Surgical Institute, University of Tennessee. He's a diplomate of American Board of Oral Maxillofacial Surgeons, as well as implant committee member of American Association of Oral Maxillofacial Surgeons. Dr. Martin has published several articles and book chapters during his career. Over the last 25 years, he has developed over 20 surgical instruments with several major instrument companies that are utilized by dentists and surgeons throughout the world. Over the last 11 years, he has utilized a digital workflow to improve patient outcomes and is considered an early adopter, especially as a maxillofacial surgeon. Dr. Martin's passion lies in education and teaching platforms. He is one of the original contributors to Dental XP since its inception and continues to lecture, teach hands-on courses throughout the organization. He also has had a passion for soft tissue around implants and has utilized both analog knowledge and digital technology to develop. Again, it's my honor and privilege to have my dear friend Richard on hot seat and welcome you again. And we are ready for your beautiful presentation, Richard.
All right. Well, thank you so much, Omid. It's quite an honor and pleasure for you to ask me to be on this list of speakers. Quite an amazing lineup. And, as you know, through XP, many of us have developed a friendship and many of us have developed pathways to teach together. I'm not sure if you quite remember this photo, but this was back in about 2015 or 2014. We were down in Florida. And here you are back here with Maurice, Basham, Paul from Cleveland, David Wong, who you've also interviewed.
Yeah.
Christian, Lars Hansen, Marcelo Ferrer. So again, you're missed, but you found a way to stay in contact with us. And I put this slide up here for the purpose of how do we get to this point? For me, as you said in my CV, the soft tissue has always been my passion in implant dentistry. Many times as maxillofacial surgeons, we get this knock of not being able to manage or develop soft tissue. So, I took that as my charge to become, much better at this for my patient benefit. So as you can see from the people that I've had as mentors, Maurice Salama, Pat Allen, Dean Vafiatis, Agnini brothers, even way back in the early days to where one of my mentors in training was a gentleman by the name of Dudley Jackman. And Dudley passed away from colon cancer in about 2008. But he always said to me, he said, Martin, when you look at it, you want to be able to look at it. You don't want to have any questions. Do your best. So that's what I set out to do in my career. And soft tissue is a little bit unusual for maxillofacial surgeons, but I always say that nobody cares, meaning the patient doesn't care what the implant is made of, what the bone graft is. All they want to do is smile and say, spare me the details, doc. I just want it to look like a tooth. So again, the development of the tissue around the tooth is very critical. So we're going to go ahead and have some goals for today. I have quite a lengthy presentation, but in watching what you've allowed us to do before, Omid, time doesn't seem to be a factor. So I'll be quite efficient here during this next hour and 10 minutes. But let's look at what we want to achieve today. The historical arrival of where I got to from in the soft tissue development, why digital provisionalization, the steps involved in the design, and really critical, the importance of a lab technician. Many of you have a inside lab or you outsource, but that lab technician and that lab technician's knowledge is very critical in this provisionalization. We want to look at immediate versus delayed, why, when, how, and variables and outcomes. So throughout the course of the lecture, I'm going to kind of show you how I do things, how you can apply things, and looking at some options, because it's not always straightforward, let's make a tooth, let's provisionalize. We're going to be faced with different options in our patient profile. So if we do it immediately or if we do it delayed, again, it's for the support of the tissue. But there was a time when, immediate loading or immediate provisionalization wasn't really a thought. And we could talk about pink and white aesthetics. I've watched a few of these so far, Omid, and, I think Michelle has spoken about pink and white. Besa, my good friend Besa, has spoken about pink and white. But now, if you search, I mean, there's at least 33,000 hits on Google about pink and white aesthetics since the 2005 paper by Frauer and, you know, with the Belzer pink and white. But at the end of the day, we got to work with the tooth that we're dealt. So, you know, digital technology over the years, at least in its application to dentistry, has grown so far. I mean, we have the ability to wax up teeth ahead of time and print, mill. But again, we can control our subcritical areas, the function of stability. And in my hands, what I like to do is I actually will do a second scan of the initial provisional and overlay the design and tweak the new prosthetics. And we'll kind of touch on how I came about doing that and who taught me that. So in every case that we do, we have some basics. You know, it's like getting up, brushing your teeth, taking a shower, having some breakfast. It's a standard that we do with each and every case. So intraoral scan of the preoperative dentition, CBCT and merging of the DICOM files. When we plan our implant position, do we do that in-house? Do we outsource it? Whichever technique that you're fine with is fine, you know, is fine with me. But again, like I said, you have to have lab technicians that are well-versed, well-educated in all digital platforms. And the subcritical, the subgingival area, in my opinion, the emergence is what we really have to pay attention to. And also we want to utilize digital smile design protocols when applicable. So just to kind of show you where I started with this is, you know, in my early days in practice back in 2002, 2001, you know, it was kind of where the start of surgeons, be it periodontists or oral surgeons, actually delivering abutments for our referrals, whether it was a stock abutment. You know, we had these little kits that we used to give to our referrals. We put it in and then we give them the snap basket kit. But again, the incidence of peri-implantitis was growing. So we started going to custom abutments, being able to customize. And, you know, I think one of the first companies that we could do this with, Omid, was the Atlantis platform. So way back, I started taking fixture level impressions, sending them over to the lab, talking to my referral doc, talking to the lab. And what I learned way back then was, even if you took a fixture level impression, you know, that was the early days of CAD/CAM technology. So once you took that impression and Jimmy picked it up in his Hyundai and drove it back to the lab and poured it up, he put it in a lab scanner. You know, that was put in a lab scanner and it became a CAD file. So many of us were utilizing digital technology and we really didn't even know it. So what happened was I was fortunate to become a member of a group of surgeons that were starting to use intraoral scanning because I was getting frustrated. I mean, I was spending $30,000 on impression posts, analogs, and all this stuff every year, material, PVS. And I happened to be in one of my referrals offices and I saw a CEREC machine. And I was like, wow, that's interesting. You can scan an actual prep tooth and mill out a crown. I said, wow. And as a part of this group, I went to an AO meeting and I saw a 3M scan, I think it was a 3M lava scanner where, you know, you powder the tooth and then powder the scan body and take a digital impression. And I was like, wow. So I purchased an iTero. And what I did was I started doing intraoral scanning of said buttons. So here you see, this was the 3-shape encode scan body that had all the digital coding on the top. And this is kind of where I started scanning this and then evolved to, you know, the Alio scan bodies. And again, now I was able to, in the office, design abutments or scan for the design of abutments and eliminate the step of the lab coming to pick up the models. And I was actually able to share these with my referrals also. So if you look at this intraoral scan, I mean, look how fast we're able to do this now, okay? I mean, once we capture this flat surface, right here, we're finished. That's it. And I started with an Itero and I moved over to a Trios. And the reason why I did that was at the time I thought the Trios technology was quite a bit better. And what I also learned was that once the case got to the lab, all the dental designer, the model builder, it was all 3Shape software. So to get a 3Shape machine in the office to transition over was essentially a no-brainer. I mean, once I finished scanning, within minutes, the lab actually had the file. And what I also learned was that the machine wouldn't accept the file unless it was complete. So as far as digital abutment design, what I thought was, in the early days when I was started doing custom abutments for my referrals, many of them didn't like it because what I didn't know was that I would just scan and send it off. And I didn't know that I could specify where to put my margins, what to do. The Atlantis platform had several options, but many of us weren't aware of what we could, what we could specify. So once we learned that, then I think that really, digital abutments really, took off and running, and things that we could control, the shoulder height. And again, we were always told to put implants 2 to 3 millimeters below the CEJ of the adjacent teeth. And then we were told, well, we can put them a little deeper to help develop the emergence profile. And many of us were a little nervous about that because we thought about cement retention. Well, when you can raise the shoulder and actually move the screw access hole, that solved a lot of those issues. But again, there was many of us that weren't paying attention to that. They weren't paying attention to the emergence profile and exactly what we could do with these digital abutments. So if you take a look at this case, this looks fairly deep for a molar implant, but look at where my margins are and look at that bone maintenance. And so this is where the light bulb kind of went off for me, is what I started to do for my referral docs now, and trying to get them to use the technology, was I would provisionalize every single tooth, whether it was a molar, whether it was an anterior tooth. And I saw that the anatomy that we could put into these provisionals was amazing. And once we put them in, we had very little adjustments. The contacts were right on. So again, the light bulb went off and I said, well, let's see what we can do with anterior teeth now. And if I started to kind of develop a little bit of a knowledge here and talk to some of my colleagues, my prosthodontic colleagues, my highly restorative colleagues, and kind of get more prosthetic knowledge from a surgical, standpoint. And what my referrals, they were, I met some pushback at first because again, they say, well, as a surgeon, you're doing too much. Stick to surgery, not the prosthetics. But what I said to them, I said, look at what can be done. I'm just showing you. I'm just a conduit. This is what you can do, what you can, discuss with the lab. So again, we look at what we could do with these provisionals, and we learned that we could scan these provisionals to actually develop our final. So here you see one of the classic papers from Monaco and Zucchelli here about scanning the provisional restorations. And again, a technique that was also taught to me and kind of refined through the Agnini brothers with their paper with Steve Chu, Dave Garber, and Maurice. And again, I'm still very close to my colleagues, Agnini brothers, as well as Dean Vafiatis here, who put out a paper about, again, scanning and making a provisional ahead of time, following the root, crown, and form technique. And here you see me sitting here. I'm going to actually jump back one slide here. And if you see the Andrea and Alessandro Agnini with their book, which I think they're about to put out the second edition here, that was the 2014, and I think they're rewriting a new one coming out. And then, of course, the Team Atlanta crew here that, you just look through our literature, look at all the people that you've had speak so far, Omid, and many of them, refer back to the importance of Team Atlanta in implant dentistry. And then Dean here was actually my dental school prosto professor. He had shortly finished pros training at NYU and actually joined the team there. And so he was, fairly a young guy back then, still not that old now, but kind of took me under his wing back in dental school. And we've actually stayed in touch since then. So that's 28, almost over 30 years of friendship there. And again, these, if you need any of the articles, just let me know. I'll give you my email at the end. But again, the importance of lab partners. You know, when you're doing digital technology, digital provisionalization and your finals, because again, your provisional is the backbone for your final. So you've got to have a close relationship with a, you know, with a lab. And so this lab happens to be next door to my office where I do a lot of my anterior work with. I'm over there 3 or 4 times a week, you know, just looking at how, you know, how the lab runs. And, you know, this is Ralph here, and Ralph is like, here he goes again. You know, I need to get on a plane and get out of here. All my ideas. And Jimmy's like, does he think I'm picking these up by Wi-Fi? Ralph is like, you know what? Maybe the space shuttle. I drop an anvil on his head. And Jimmy's like, I get it. I get what he's talking about. Because what I learned was that the more I went over to the lab, the more I learned. The more I learned about design, the more I learned about, you know, what the lab went through in order to design, you know, abutments, crowns, because as many of you know, a lot of the labs, they didn't want to lose your business. So they, even if your impression was inadequate or it wasn't perfect, you know, the labs found a way to improve, to fix, you know, so as to improve the outcome. So what we're going to look at here is we're going to run over a couple of cases, and we're going to show you the initial backbone, and then we're going to go through about 8 cases with different complexity. So every case is the same: an intraoral scan, a CBCT, and then either in-house or online planning session. And I'm going to show you this little video because this is what I do. This is what I do in telling the lab what I need from them. Okay? Because again, the lab only knows what to do if you know what to do. It kind of sounds like a play on words, a pun, whatever you want to call it, but the lab can't do what you don't know how to do. So I like to go over to the lab, and with this technology, just learn and show them. So I'm going to show you a couple of quick videos. And I always say, whenever I show you a video, it's unedited, it's raw, but it's a real deal. It's not rehearsed. So now with these Zoom meetings, we can do a lot.
I was just reshaping it.
Can you hear that okay, Omid?
Compared to this one, this one is all nice and round. How do you want your tissue down here?
So what we can do is, if you look at that kind of that concave aspect, you know, kind of if you, can you turn it up?
So, I mean, look at this. Look at what we can do now. I mean, that's inside out. I like to call that inside out. You know, flipping the model over and looking at the subgingival contours.
See this sharp angle right here? So that will sit against the bone, okay, and my socket shield. But I want it to kind of be more concave, not umbrella. Good. All right. Hang on. Pause.
So I'm going to pause that. I'm going to move to the next video. So basically what I'm talking to Christina about is my subgingival contours, even before I do the case. And by me telling her what I need, I'm also learning what she can do and what she can't do. I mean, what is she capable of designing here, you know, prior to milling this out? And the ability to turn off and turn on the model, I mean, that's critical. And what my lab told me is, because of my conversations with them, they now can speak to other referral docs about their cases. And as one of my mentors told me, my program director, Jay Hamill Willoughby, you know, he always said to me, high tide raises all boats, meaning that your job is to not only just look at it as what I can do for me and for my patients, but look at what you can contribute to the rest of the population that's out there, the rest of your docs that's out there. So let's look at this second video here.
Why does it doesn't matter? All right. So now this is the buckle. If we can give me a little space like that.
And again,
Oh, okay.
all my conversations here and in just layman's terms. So you may hear me say something a little quirky, but again, it makes sense.
More like that.
Even come in right. Yes, yes, bring that in. Perfect. And then on the palette, when you get to
Let's turn the model back on.
like the palette, if you take the palette down, kind of not like that, but going back to the palette. If you take this palette, kind of turn it a little bit to the right. So kind of take this out right here.
All right, I got to get this back in focus here. There we go. So one of the areas that we routinely do not pay attention to is the palatal design also of our prosthetics. Very critical, very critical. And with the technology, you have the ability to control every aspect of the design. So we're just going to kind of move ahead here, turn the model back on.
Turn the model back on.
Sorry about that. Yeah. So, you know, one of the things that's really important here is just understanding about design. I mean, as many years as I've done this, I still continue to learn, and I'm still baffled by what we are able to do with digital technology. So once we've got our design now, we're going to go ahead and print out a model. And I like to actually use cylinders. I like to use cylinders as temporaries instead of temporary abutments. We have the ability to mill out temporary abutments, provisional abutments out of PEEK. I did that, you know, several times, and I didn't like the unpredictability of that. So I like cylinders, and I believe I heard Michelle and Besa, you know, talk about using cylinders and being able to develop tissue a bit better. So I like to combine my analog knowledge with my digital knowledge in what I call Digilog. So we're going to print out the model, but we're going to put the provisional post in there by hand. We're going to mill out the tooth, and then we're ready to go. And again, this is what we designed with Christina. And then here is our subgingival contour or subcritical area, as well as on the palate. We go into surgery, and what we see here is once we've prepared our socket shield, we've placed our implant, this critical prosthetic space. And we'll discuss that later on in regards to socket shield. But I always like to say, you know, no matter if we do socket shield or we do traditional immediate implant placement, our implant in the maxilla always goes towards the palate. And we always need this prosthetic space, no matter what. So we design in that way as to help to support our tissue, but not put too much pressure buccolingually, mesiodistally on our papilla area, because we don't want to squeeze those out. We don't want to cut off our blood supply, and we want that bone, you know, that bone and tissue maintenance. So here you can see after about 3 or 4 weeks here, nice tissue healing around. And, you know, Omid, as a periodontist, you're probably looking at this area right here and say, Martin, why didn't you treat that area? Why didn't you advance the tissue down there? And, you know, we'll talk about that a little later. But this is the first time we've removed the provisional, and you can see some nice healing, a bit of bleeding, which means what? That we had some attachments. So, you know, that's good there. But look at our volume here. Look at our volume. And all throughout the lecture, we'll talk about volume. Now let's kind of move down the road here, and we'll look at simple yet complex. Okay, what we're doing looks very simple, but there's a lot of complexity into how we design and how we get there. So these are some of my favorite cases, Omid. Congenitally missing laterals. I mean, I love these cases. The challenge is there, but when you get a very nice aesthetic and functional result, it's the patient that really benefits from this. So I always like to look at these cases in the same way. You're always going to see this buccal hollow. And the reason why is because there's no natural tooth there to help develop the alveolus and bring down the bone and bring down that interproximal bone. The canines are always going to look like this, almost going to look like they're not erupted all the way, because technically they're not. They're not. They haven't, had that alveolar bone to slide down on the lateral aspect here. And you're always going to have these short papillas, both on the distal of the centrals and on the mesial of the canines. Now, Vince Kokich, who passed away recently, orthodontist in Washington State, one of his principles were, erupt the canine into the lateral position and distalize it to give you that bone and development. I mean, that's doable, but that's a long time with teeth being under, function and being under a force. And like I said, no disrespect to Dr. Kokich, he's, one of the pioneers in this whole congenitally missing lateral deal. But I developed kind of a treatment algorithm for these type of cases that I approach the same way each and every time. So we're going to go ahead and plan. And again, I work closely with my orthodontist, because you don't want to see one of these cases, whether it's a adult or an adolescent, where you get to the point where it's time for the orthodontics to be removed and you're a millimeter short, or you have divergent roots. So check the spacing. I follow these kids. I mean, I start with these kids, young people 12 years old, and I may not treat them till 20, 21. And, they grow up in my practice like I was a pediatric, a pediatric dentist. But it's really critical. And I'll show you another case down the road, because these folks spend a lot of time and a lot of money in your office. You're talking about 2 teeth here. I mean, you can run as high as, for the implants and prosthetics alone, $20,000, dollars if you don't, watch your dollars and cents. So we're going to go ahead and plan the case. And then we're going to go into surgery. We have our surgical guide with our hex timing here. Okay. And in this case, I determined that I had enough room, I had enough bone to place the implant. But in all these cases, I always graft. And most of them, I'm able to do my bone and soft tissue graft at the same time. And again, Omid, you've interviewed many of my friends on here, many of my friends that, your friends that, we're in constant contact with. And, Luis spoke yesterday, Besa spoke about the ability of using soft tissue grafts as a sole form of augmentation, but also just the volume to maintain. And I'm a big fan of tuberosities in this anterior area. And the reason why is because I've seen cases that I've done 10 years later, and teeth look great, but my soft tissue volume was not where I thought it could be or where it should be. So I developed my little technique here utilizing tuberosity grafts. And actually, I don't have a slide of this, but again, de-epithelializing the top layer, splitting it, cleaning it off again, and then using them in the areas. And I know Howie has a paper out there about the tuberosity grafts and the growth, but in my hands, I have not experienced that. So again, I continue to use these when possible, but I still do use, the traditional palate at times if I can't get enough from the area. And again, tuberosity postoperatively is a lot less painful than straight palate. So we're going to go ahead, tuck our grafts in, and we're going to go ahead and provisionalize. Now, I had planned this case digitally ahead of time, provisionals, all that. And then right at the time of surgery, the patient told me, well, I'm going to Africa in 2 or 3 weeks. And I got a little leery about immediately provisionalizing. So what I did was we used a backup transitional partial as my friend, prosthodontist LSU trained Paulino Castellan would tell me, do not call it a flipper, call it a transitional partial. So we call it transitional partial. But again, we had still digitally designed the case. So whether I had a transitional partial or I had actual provisional cylinders, the design was still there. I mean, look at the design of the incisal edges in relation to the natural teeth. And this is a removable prosthesis. So we're going to go ahead and look at about 7 weeks. And one of the things that I'm going to touch on in this presentation also is what I like to call digital healing or patient monitoring. And I always, every time the patient comes in, we intraoral scan the patient every single time during the healing phase. And I'll show you why we do that. But if we look at photo healing versus digital healing, I mean, it's very close. So here we have our provisionals that we had milled out ahead of time. And actually what we were able to do is while the patient was healing and we were scanning her, we also scanned her with the, I'm going to call it flipper, with the flipper in place. And we went back and tweaked some of the design and milled out some new provisionals. And so here you see, same printed model, milled teeth, try to give the patient as natural looking as possible. We're going to go ahead and put them in. And these are our milled provisionals, probably 10 weeks, 11 weeks down, down the road. And what you'll notice here is take a look. Remember what I told you about these canines and lack of papilla. But look at the mesial. Look at that. They're always going to be short. In congenitally missing teeth, no matter how great you are, how much you manage the soft tissue, how much you graft, they're always going to be short compared to what we, think is ideal. But you always have to measure where you're starting from so that, you can address this area. But I'm going to do a little trimming here of my provisionals. So just keep an eye on that area and take a look now. It's not perfect, but it's better than it was before. Look at the mesial papillas. And again, scanning. This was done, with scanning, with intraoral scanning and design and copy paste, technology. So that's filled in some. You look at the opposite side. And can we do a little bit more adjustment here? Yeah, we could. But again, I mean, that's an acceptable result from where we started. So let's move on to another case, what I like to call a shared design. And again, it's the same thing, Omid, every time. Canines look like they could do with some crown lengthening, buccal hollow. And even as actually Luis touched on this, Besa touched on this yesterday, or excuse me, when he gave his lecture, is that you may look deficient clinically, and then radiographically you see you have enough bone, right? So do you need bone graft every time or just tissue graft? But again, there's so much more that could be done to this case. Again, we could crown lengthen. Could we do some more orthodontics? Yeah. But I always like to say, these patients have been in treatment for a long time. The patient gets tired. The teeth get tired. I mean, you don't want to continuously put teeth under orthodontic force because, as we know, we can have some resorptive issues, and then the wallet gets tired. I mean, how much money can I spend on these teeth? So again, we call these Texas toast grafts. Everything's bigger in Texas, so. Again, some nice tuberosity grafts. Again, this is one graft that is split, deepithelialized, fat, and I like to split these, butterfly them, and kind of thin them down some more. And again, in my hands, I don't have, any inclusion issues. And here's what I call the shared design. So this is not something that I invented, but I saw it in another software platform in another from another company, and I spoke to my lab guys and I said, hey, can we do this in 3 shape? are you able to replicate and make these kind of jigs that we would see on the teeth, and I'll show you that in a little bit, that we see these Duralay pattern jigs, to place abutments. So this, technology is not original, but I asked my guys to incorporate it into the 3Shape software to mill these out for me. And here you see screw access holes here, and just going to sit on top. And then what we would do is just separate after we picked up the teeth. Printed model, removable, removable dies. I mean, that's just powerful. And if we look, this is about a week after. I mean, this is not the most aesthetic looking case here. The zeniths are off, but stay with me on this, and we'll show you how we use technology. So a few weeks later, look at the soft tissue response. Remember, no papilla. Now we have papilla. Now we have papilla. Okay. And when you look at the final restorations, I mean, that's acceptable. Again, we can clean up these areas a bit here. But again, from where we started with this case, and even started with the provisional phase, this is, I think, a huge improvement, because what we were also able to do, we were able to lengthen, so we could scan, redesign, and then essentially give the patient an acceptable result. So I spoke earlier about the importance of scanning the patient every time that they came into the office. And here's a nice a paper from Nelson Silva, Jonathan Friends, and their group. And Nelson has developed quite a bit of the technology within the 3Shape, the 3Shape workflow. But again, looking at an intraoral scanner as an iPad with many applications, not just can I scan abutments, can I, scan to do some veneers, but look at it as a patient monitoring tool. So every time the patient comes in, you scan the patient, okay? So the initial presentation here of this patient, congenitally missing, we're gonna do some work over here. And here we have 6 scans. So 6 visits. But let's take a look. Through the technology, which again, you were shown, I believe, in Base's lecture, you have the ability to overlay all of these files. And why is that important? Why? Because, in all that we do in dentistry, in implant dentistry, we want to measure our outcomes. We're always looking at improving our outcomes. We improve our outcomes, we improve our patient satisfaction, and we can be happy and say, hey, look, you know what? The time that I've invested, the technology that I'm invested in, there's a benefit to the patient, there's a benefit to my practice. And again, for those of us, myself and you, Omid, that we like to teach and share, we come from a background of always inclusive, right? So it's very easy for us to share and teach each other, because I say the more you teach, the more you learn. Okay, so keep that in mind. So if we look at this timeline of when the patient each visit, and we just overlay it, we have the ability to monitor things like this. Who would think that you could take a you could take a intraoral scan and measure a bone graft? But that's what we're doing right here. This is our initial, okay? And this is how the patient was grafted. And what we can do is we can measure the blue line to the yellow line to see what was our bone gain, what was our soft tissue gain. So that's just thinking outside the box. And another application also is for you as a periodontist, Omid, is you can monitor the wear of teeth as well as the attrition or the recession of the soft tissue over time. And Mary says, oh, I've been taking care of my my gums, and you say, well, Mary, look, here's day 1 and here's where we are now. I need you to do a little bit better job. So things like that we're able to do. And if you just look at the simulation, these are all the visits together. And let's look at this one also. You can take a look. There's our graft, healing abutment, scan body, and that's Nelson and Heinrich Brown there. So thank you, Nelson. So as we move on, let's look at a few resorption cases and how we manage that. Because again, as we know, many of our or most of the anterior teeth that we treat are either internal resorption, external resorption, root canal fractured tooth, or a combination of all these things, as well as trauma. As a maxillofacial surgeon, yes, I do see some avulsions and teeth displaced. So again, the management of anterior teeth from the implant side, as an oral surgeon, we should have a vast knowledge, background, and abilities. So let's take a look at Pat here, and we look at this, and what do you think? I mean, those are beautiful teeth, thin biotype, but I mean, those are really nice looking teeth. I actually did some implant work for her about 6 or 7 years ago in the anterior mandible. And so now she's back, because take a look here. Just remember this little area right here, because we have a resorptive process going on. So that tooth is internal resorption. You can't really see it that well on this plan, but this is what's going on with that tooth. So it's non-restorable. And again, combination of the DICOM files, the intraoral scan, we're going to plan on where to place our implant. And Howie Gluckman, another good friend of mine and yours, Omid, and who's been here on the hot seat, he talks about the radial root plane, angulation, when should you do shield, when you shouldn't do shield. And, here you see this design here. And he spoke about the perforation of the labial plate. So if you look at the inclination, angulation of this tooth, I mean, it's tough. And I don't have a very wide alveolus here. But we're going to go ahead and plan, because that's what digital technology helps us to do. It helps us to plan ahead of time where to place our implant. Can we get the adequate screw access hole? So on this, I think I was going to move it over a little bit, and we could also do, an angled abutment here to change that axis. But again, what I also wanted to do was measure out for my socket shield here, trying to leave adequate thickness of the shield and support this thin, this thin buccal plate. And again, as far as cotton roll to show our soft tissue, we did this a little bit different in this here, but you can see, we've outlined our soft tissue profile. And here's our plan. And again, with the technology, you can see this in all, different aspects of the bone. So this is what we've got going on here. I mean, there's no way that you could have restored that you couldn't do a root canal, crown lengthening, which I would not advise in this area. I mean, that tooth is shot, but the buccal aspects of that tooth are in great shape. So we're going to go ahead and prep, replace our implant. And if you look real close, you can see just a little bit of the shield there, temporary cylinder. And again, what I did in this case was I actually I planned the case, but I actually planned to use the natural tooth, because what I looked at was, remember that radial root plane. And I said, well, I want to immediately load it, but I want to have a little backup. So what I did was I actually immediately loaded it, but I used the Essex as kind of a guide also. So I kind of as a backup here. And again, I told you earlier on in the lecture, each case that I show you will involve digital provisionalization, but it'll show you a little tweak on each and every case. Because again, remember what I said earlier on, we have to treat the tooth that we're dealt. So yes, I can give you a roadmap of how I do things, But at the end of the day, the clinical decision is left to you. And you just have to think, not necessarily outside the box, but think outside the mouth is what I like to say. Think about your planning outside of the mouth and then take it into the oral cavity. So here, a few weeks down the road, 6, 8 weeks, we take it out, a little bloody again, but still look at that tissue volume. And we're going to go ahead now and take that plan and now make a provisional from our original plan with a little bit of tweaking, scanning, and recontouring. So here's our new provisional. And again, I didn't like it when I tried it in. I said, let me make a few adjustments. And so chair side here, I'm still making a few adjustments because I still have analog knowledge. I still have all the knowledge of when I used to do this completely chair side. You take a shell, or you had a stone cast before that you would, put the Essex material on top. Then you would inject the acrylic in there. You'd have the temporary post in. You'd seat it. You'd, cross your fingers. When you took it out, that you didn't pull out the whole implant. Then you took that. Then you'd reshape it. So you have that analog knowledge. Remember what I said, digitalog. So you have analog knowledge gives you digital flexibility. Okay. So yes, that's me using actually, that's a 703 carbide burr that we traditionally use to take out wisdom teeth. So, I'm able to use that to do a little trimming. And yes, I do use diamonds and I do use contra angles too. But again, he who has the tools in his bag must know how to use each and every one. And then, just making sure that area, that subcritical area, again, a little modification. And we put it in, let it sit for a few weeks. And again, a little gray right here. And that's, probably from a little metal show through maybe. Or do you think it's a vascularity issue? We'll see. But this is our final crown. No more graying. A little white, but I think aesthetically, that's a nice case. And remember, we've got a little bit of a shorter papilla here, but this is where we actually had some bone loss and where our resorption process was headed. But if you compare, the contralateral side, I think that's a fairly nice result. From a bird's eye or from an occlusal view, that's, very nice volume maintenance. From a lateral aspect, I like to say no tissue, no issue, because I haven't done a soft tissue graft there. This is pure socket shield and maintenance of bundle bone and PDL. So let's look at some variables. Variables, like I said, each case, I'm going to show you something a little different just to get you to think, okay? Think. Each case, again, we have our, roadmap of the basics that we do, but we have to think about each case as an individual entity. So when we look at this case here, you can see this patient's already in some form of a provisional crown here. Again, a root canal tooth, fracture, resorption, and you can see the tissue starting to move apically, and we have a little bit of a rotation here. Now, again, but we've got decent papilla. So what am I going to do here? We're going to plan the case. The tooth was stable, met all the criteria for socket shield. So we're going to go ahead and do socket shield again. And we're going to use that actual provisional crown. Although I scanned the patient and did all the planning, she already had a provisional crown. So I was going to use that provisional crown and tweak it a little bit. So now when I put it back in, I decided I wanted to offset it a little bit towards the palate and tried to rotate it back to the mesial. And I wanted to leave a little gap here, a little bit of PRF only under the flap to allow that tissue to migrate coronally. Now, in your series here, Omid, you've had talks about tissue moving coronally, I actually like tissue to move coronally. I love when tissue moves coronally because then it gives me the ability to put it back where it needs to be. So in my hands, I like that. And then if you look at this from the radiograph here, you can see there's the implant, there's our socket shield right there, and that thin, just such a thin labial plate, but again, another thin alveolus. So there, let's let it heal. 8-10 weeks down the road, we're starting to see that tissue filling in. And this lady was a school teacher, so it was her visits were spread out, which actually worked out, worked out well. But you can see open bite, okay, or excuse, a little bit open bite and increased overjet. So at about 24 weeks, we're looking good, okay, and we can see where we've filled in quite nicely. And we have a lot of tissue to help to reshape. Yes, we can work on this a bit more, but again, I think we're doing okay so far, right? Not bad. There we go. So my referral is going to go ahead and scan it. We're going to make our final crown. Healthy palatal tissue. And here's the final crown. Looks pretty good, wouldn't you say? From this lateral view. Again, you can see the tissue here. Nice volume. Looks great from that aspect, right?
Yeah.
Beautiful. Beautiful. I mean, and that's just unbelievable. I mean, no soft tissue grafts, just socket shield, a little Nova bone in the gap, little piece of PRF strip. You would say, Omid, that looks great?
Yeah, it's truly
Yeah.
beautiful. Truly beautiful.
But look at this. But look at this. Look at this. I mean, if we talk about pink and white aesthetic score, this is a failure. If you look at it, if you combine them together. Yeah. And what happened here? I mean, what happened? I mean, look, again, if you look at this contour here, this has to do with the contours of the crown, in my opinion. And I mean, yes, I could, we could displace tissue a bunch, touch it up a bunch, but did I create this when I initially provisionalized? Is this my fault? Right? Because remember what I said was initially I, put it towards the palate a little bit. I wanted the tissue to come in. And I mean, I think I created this issue. This was my fault. But when I show you this picture, this is my saving grace right here. Yeah. This is my saving grace because this is very healthy tissue, very healthy. So what am I going to do? I'm going to use digital technology to help me out. I'm going to take out that crown. I'm going to flow some composite in there. I'm going to recreate my subgingival. I kind of started coining the term that I call my subgingival aesthetics. Mm-hmm. So I'm going to recreate my subgingival aesthetics. I'm going to go ahead and scan the case again and now change the design a bit. And we're still kind of working through this case here. Some of the cases that I'll show you, we've got kind of been snafu'd a bit by COVID. So once that, once we get back to in business, we'll get this case finished and I'll share it with you down the road, Omid. And, you mentioned that, you would put a few of my cases in your book, and thank you so much. But in those cases, I know that, you'll see where, especially the one with the primary and the ankylose, that's a generally missing case too. But you see how technology, one of the, we can talk about one abutment, one time, minimal removal. But again, in my hands, what I've seen in socket shield with very healthy tissue and that maintenance of the bundle bone and the PDL, I mean, man, that just, that almost gives us like 9 lives per se. So we'll go ahead and scan again. And like I said, we're still in the works on that case. So well, as we move ahead, just to show you, I do soft tissue grafts at times, again, on anterior central incisors. It's not always, socket shield. We can't always do socket shield, but when I do it, I try to utilize a technique, the surgical veneer grafting by the Agnini brothers and Maurice. They have their published paper and about 2 years ago, 3 years ago, and now we're coming out with a 5-year paper. So I like to call this, my modified SVG, because in the SVG technique, it means that you immediately provisionalize every case to kind of seal in the content. But here you have a case, again, thin biotype, but very nice looking, very healthy looking teeth. But again, the left central incisor is non-restorable. Resorption, fracture. So we're going to go ahead and remove that tooth. We're going to place the implant. And we're going to go ahead and do our split dissection here to create our pocket for our graft, as described in the Agnini brothers paper. And so I like to use these blades here. Nice little dissection. This is not the Viper blade, but a blade similar to it. We're going to harvest our graft again I told you I don't always do tuberosity. So just to prove to you that I do use palate, and again, a little deeper, a little thicker than traditional technique. Going to go ahead and de-epithelialize it, thin it out a bit. Going to go ahead and put it in that pocket that we've created. Secure it. Pack a little additional graft, composite graft in the gap there. Piece of PRF over top. And again, I did not immediately load this, but I did design the flipper to the Essex to ideal contours, and we're going to go ahead and use that in this case. So there we are, immediate post-op, and then you can see that healing. A few weeks later, time for to get the sutures out. And again, another COVID interruption case. What about the mandible? All we show quite a few maxillary cases, maxillary, but what about the mandible? That can be an aesthetic zone too. We can have patients that, smile and they do show their lower teeth. But again, in the anterior mandible, very thin tissue and at times very prominent roots, very thin bone. So let's take a look at this tooth. Again, it's been root canaled, it's fractured. Look at the root prominence here. Paper thin, what I like to call paper thin biotype. Although a nice gingival margin here is still, paper thin. You can see the vascularity through the tissue. So what am I going to do here? Do I take out this tooth, bone graft, implant? I mean, no matter what I do here, if I take out the entire tooth, I'm going to have over time a huge resorption and a hygiene and a maintenance issue over time. So one of the more difficult cases to do, but we're going to socket shield it. So here you see I've decoronated the area here. I'm taking out the root canal contents. I like to use a file to do that, but you can, whatever technique you like, method you like from the socket shield technique is fine. And then I'm not loading this because take a look at this gap here. This is my socket shield here, my incredibly thin bone. So again, I'm going to show you a different method. I'm just going to, use a removable transitional partial here. And then once we're healed, again, we're going to use a provisional cylinder and continue to shape. But look at that healing. You can still see that root prominence there, but look at the migration of my soft tissue. and 14 days after putting in the provisional. I think that's acceptable. And we take it out, and remember, we had this huge gap between the implant, the shield, and the thin buccal plate. And yes, we grafted the gap. And I believe in this case, I probably used some some cortical cancellous and some PRF. But again, there we are. And you look at the depth of the implant in relation to the tissue from a lateral aspect, following the natural curve. And we maybe even had a little bit of tissue gain. What do you think? Maybe so?
Yeah.
And then take a look here, because you see the canine, the number 22, or let's see, what would that be? Would that be 3 in universal? But again, look at these two canines. Pretty close. Pretty close. Just need a little bit more aesthetics on the crown. But again, I mean, if I had removed that entire tooth, that would have been a really tough, tough go of it. I would have had a big, I like to call it sinkhole in this transition. And I'll show you a similar case here. So although my talk is about digital provisionalization, it's also a little bit of decision making when provisionalizing or when doing these cases. So it's a little bit of a combination here, of using the technology. And like I said, the analog knowledge. We had to know what to do before we did it. So let's look at some more variables. So what happens when you can't do the implant right away, and you have a case like this, another congenitally missing lateral, where again, a young patient out of orthodontics, what am I going to do? Am I going to keep her in a removable partial? Am I going to keep her in a retainer for 5 years? I mean, what will that do to the teeth for 5 years? How many prostheses will the patient go through in those 5 years? Will we be able to hold and maintain the tooth position for 5 years? So again, just options. So we're going to go ahead and intraoral scan, cone beam scan, plan the case like if we were going to do an implant, but we're going to make a Maryland bridge. We're going to make a Maryland bridge that we're going to bond in. And again, I didn't put the reference here, but Aurelia Salier, and excuse me if I mispronounce your name, my dear, but I didn't reference her paper here, but she published a paper in International Journal of Restorative not too long ago, or maybe 3 or 4 years ago, about the decision of using 1 wing versus 2 wings. And at the end of the day, it comes down to, what is your occlusal clearance here? I like to say, what is your occlusive clearance? Occlusive meaning that when they go into protrusive, okay, do you have that room? So this is actually milled out of Emax. And the reason why I like that, Omid, is because when I was doing these out of just straight PMMA or acrylic and they fractured, the wing would actually fracture off and you'd be in trouble. Well, in my hands, when I do these in Emax and they debond, it's still intact. So I can just come back and etch it up and bond it back up again. And, you look at the cost here, you say, well, wow, that's kind of expensive to do. And these lab costs about 120, US dollars. So again, in the long run, I don't think that's, too expensive a route to go. So let's prepare this Pontic area. Very important. Some diamond resurfacing here in this area to get a little depth control. And then we're going to go ahead and bond that in. All right. So that's the day we bonded in. Okay. Remember what I told you about the canines? Remember what I told you? Actually, let's go back a second here. Remember what I told you about the canines, the short papilla, short papilla. Because what happens, there's no alveolar development from the tooth. So that doesn't have a chance to grow coronally, short and flat across, almost like a, 30-degree angle on the distal of the central. So there it is again, bonded in 14 days. Go back 14 days. Look at that. Put a little pressure on the tissue here. And then from a facial view, what do you notice here? What do you notice? What happened? Am I more coronal?
Yeah, seems like that.
Yeah, because I designed it that way. I like more because more I can push back. For me in my hands, a little bit more gives me, a little bit of wiggle room. Okay. And again, I like to just have that volume. I haven't done any soft tissue grafting here, nothing, because again, she's, too young for implants. So I think we have about 2 more cases to go. How am I looking on time, my friend?
Perfect. I'm enjoying that
Perfect.
slide. Yeah, I'm enjoying it.
All right, man. So now this is what I call the full suite of partial extraction therapy. I'm putting everything together in these last couple of cases. Okay. So this on the left here is, really just using the technology. I was trying to make a slide here, working with my lab technician, and toggling back and forth on the the little controls on the software. And we came up with this. This is way back when about 2016, when we said, could we digitally design the shield? And something we're still working on. Have you had Isaac on yet?
Yes.
Isaac, you've had Isaac on?
He also
Yeah, and Isaac.
He talked about guided socket shielding too, with his designs
Yes.
in the what can I say, the new guided protocol that he had for some.
Yeah. So Isaac, works on this a lot, in our group. And Isaac, again, another good friend of mine and a fellow NYU graduate and a part of our, research group that I'll show you in just a minute. And there we go, right on cue. So this is our partial extraction research group. I think we have 11 countries represented. And I think you've had Howie on the show, and you've had Ehab, and you've had Isaac.
Yeah.
So far. So, but, and one member that we call the queen, our only female member here, so we call her the queen. But let's take a look at this case. And again, I've been in practice 22 years. I've been in solo practice for 19 years. So I have quite a cachet of patients over the years, and I've been able to watch these patients grow young, grow old. And this case is one where I've placed these posterior implants about 7 years ago, and some anterior implants here about the same time. And we always knew at some point we'd get to this point. So remember what I said, at some point we would get to this point. And what I've noticed here was, just look at the drop off. This is what I was going to tell you. Look at that canine eminence, and then just look at the loss of volume. The implants are fine, the bone is healthy, but look at the tissue here. Look at what we've lost. And again, over here, natural teeth. I believe this might be, the 13 might be an implant, but it's a natural tooth. But what we're having is root caries. We're having a lot of root caries going on. This patient is 72, I believe. Recession of the tissue. cervical caries. So you get to a point and you say, well, what do we do? Do we keep extract one implant, extract one implant, extract one implant? That becomes expensive, and we know what's going on. And as you know, every time we put one implant next to the other, we have aesthetic challenges. So we sit down, we make a decision that we're going to remove the remaining 6 anterior teeth, and we're going to do some implant retained bridges. But with the partial extraction in our pocket, let's see what we can do. So here, I've leveled or decoronated all the teeth in the area. And we've got cervical decay, we've got root, root resorption, root canal issues here. So what I decided to do, Omid, we're going to do partial extraction or socket shield, root submergence. So that's, Henry Salama and the Team Atlanta, again, publishing that many years back, root submergence, okay? And again, socket shield, as you know, introduced by Herzler. And again, Howie, Maurice, started, publishing that and changing the technique as far as bone level of the shield. Again, you've had Howie on, so, I know you've gone over that at length. But again, just to show you what we can do is just kind of thinking outside of the box. Because again, I mean, if you take a look real close, I mean, look at this drop off. I mean, you can look at the drop off between the canine and the premolar. So we're going to go ahead and digitally plan and digitally design and do that. And there's our final X-ray, or excuse me, final photograph here. So implant, root submergence, and if you look closely here, you can see where I've made this, I've contoured it or made it concave to accept my prosthesis. So the question here now, Omid, what am I going to do? Am I going to immediately load this, or am I going to use a transitional partial? What do you think?
I think depend on your stability. Maybe you can go also with immediate loading, but I prefer to go with the stage with the transitional, as you said, to let the tissue heal better. That's just my opinion.
Perfect. So we're going to put, we're going to graph the gaps. We're going to put some, what I like to call PRF pouches, or, I'm a big fan of pocket squares when I have on my, my suit. And so, as the French would say, pouche. So I like to, use these PRF pouches throughout the, throughout the tissue. And then at about, I think we're maybe about 6 weeks down the road here, you can see our healing, okay? And, maybe a few bone granules here, but again, look at that canine and look at the drop off. And I'm gonna show you something else too. So you're right, this is what I used, but I digitally designed it ahead of time, and we made it ovate to fit each socket individually. We customized each socket. So in the last case, I'm gonna kind of show you, a little different. But this right here is what we call made to measure. Okay, so whenever you digitally provisionalize, you have the ability to do what I call made to measure. Okay, so remember that. So again, we're getting ready to scan up for our provisional. So this is, again, our dental designer. And earlier I said, we had the ability to utilize multiple softwares, but multiple platforms within the same software. So again, dental designer here, designing, doing our wax ups ahead of time. And pay close attention here, because remember that canine where we had the apical migration of the tissue?
Mm-hmm.
So here's our design, okay? We're gonna mill that out. Again, each one will have a little bit of a concavity. And so now we move to our next provisional phase now. Remember what I told you earlier. I at times in these cases, I will use two sets of provisionals, whether it's a removable prosthesis or it's a fixed prosthesis. Again, you could look at things as far as cost, time, but I always say, the time it takes for us to do an implant case is about this long. In a patient's lifetime, that is this long. So this is not a big deal. It's like going to college, or going to dental school. I mean, how many years ago did we complete dental school? So long ago. I mean, I've been practicing now, out of dental school. I've been out of dental school for 27 years. And it seems like yesterday. I still have many friends from dental school, but that was an investment, from dental school, then oral surgery, then fellowship. And you say, oh my gosh, I'm in school forever. But I mean, that seems like yesterday. And I can't believe I've been practicing for this period of time. I can't believe I've known you for at least 10 years, at least, So again, we go into our second set of provisionals. And in our provisionals, take a look already. We've corrected that. Remember that apical recession of the tissue? Over here, not so much. We've had a little bit of exposure that I'm cleaning up, but I'm going to tell you why you have the difference in the two canines. And then now we're getting ready to go final. My referral took out the provisional. And I mean, take a look. Take a look now at this healthy tissue. Remember, I had a little exposure here, managed. Little exposure, managed. Healthy tissue. Pontic sites, pontic sites. Now let's design for the final. So I'm working with my referral doc. He's working with the lab. We're in communication. We've done a cut back here. So milled zirconia, and then we're cutting back to layer the porcelain on. I believe this is like CM9 to layer on in this area. And the pontic areas will be green just because of, again, that's, in the software to indicate that these are pontic areas. And then here's our final prosthesis. Remember the canines? Okay. So the number 11, I've managed. That's my perio there, digital periodontist, Omid. Digital periodontology. That's our next topic. But why is this canine still apical? Because it's next to the implant. That's why. That's that implant fall off. So if you take a look here, there's that. But whereas on the other side, I still have bundle bone, I still have root. And in your principles of periodontology and grafting, you know that adjacent teeth, papilla bone is very important. So through prosthetics, we're able to correct that. I mean, and that's, an acceptable result. You can always say you can have a little bit nicer porcelain. You could always open up the bridge. You could always do, but I mean, if you look at these, from where we started here.
And Richard, I just wanted to mention something regarding this case. If you go back to the surgery, when you showed an occlusal view that all the shield, root submerged, everything was clear. You had one slide from the occlusal view at the time, end of the surgery. Yeah, go more back. Yeah, I think this one.
Mm-hmm.
So the position of the right canine seems to be perfect under the cingulum, and there is a shield, and everything about the contour seems perfect. But now, if you go to the healed ridge, a few slides after this, yeah, no, after opening it, after the removing the provisional.
Oh, okay. Where did that slide go? Where did it go?
I think the one that you mentioned, RST and Socket Shield, you mentioned all of them.
Yeah, I know exactly what you're talking about. I'm trying to figure out where it went. Hang on 1 second. I do not know where that slide. Oh, here it is. Here it is.
Yeah,
Okay, yeah, it's
yeah,
down here. Yeah, it's down here.
yeah.
Yeah, this
Here,
one.
when we look at
Okay.
this slide comparing to that one, I don't know. It seems that that implant seems like it has moved to the buccal. I don't know if it's.
I I think, Omid, I think what happened here, it's the angle of the camera.
Uh-huh.
I think I know what you're saying. I think it's the camera angle.
Yeah,
Because if you see this picture slightly rotated to the left.
yeah,
You see, if you look, you see how it's kind of like rotated this way.
exactly.
Because here's the shield here, and this is the head of the implant right here. But yeah, I think it's rotated.
Yeah, so I thought that maybe because here the position seems to be perfect, and I thought that maybe
Mm-hmm.
it's because of the buccally inclined implant placement that led to a little bit soft tissue migration to the apical. Just my thought, but when I look at this slide, everything is in the place and the shield is there, so there was no way for the soft tissue to migrate apically. And what I wanted to ask was that why? I mean, we cannot build up the bone, but maybe with the soft tissue graft at the time of the uh,
Yes.
re-entry, maybe we can enhance the soft tissue level more to the coronal.
Actually, Omid, you're correct. In certain cases, yes, we can make the decision to soft tissue graft, and I will insert when I'm doing, 3, 4 like this. At times, I will make that decision to graft, and I think in this case, I attempted to do that with the PRF. In this case, some of the I don't know if you have her coming on the show, but I think she's out of USC, Alina Kalinsky. May not have pronounced her name correctly. She
We had
talks a lot about using PRF
yeah, we had
as a,
my husband in the show,
you had her husband. Yeah, okay.
Amir.
But I mean, you
Alexander
got
Alam.
everybody on here, man.
Yeah,
Yep, yep. So, but if you look at this one now, Omid, look at this view. You can see, look at the position of the implant. You see that now,
yeah,
slightly buccal.
yeah,
So that kind of gives you more so. But I think, let's go ahead here. And you see, kind of using there's probably another piece of PRF
yeah,
underneath. But again, I mean, we do have good soft tissue coverage.
mm-hmm.
And, you know, you try to be conservative in raising your flaps to, minimize the recession, especially against adjacent implants. But yes, I could have put a connective tissue, a nice, connective tissue graft underneath. Absolutely. Especially, in this case. To help that out. And you can actually see, a little bit of an exposure here, but manage that no problem. This is a bit more of a little bit of a, could you call this an internal exposure versus external? Howie talks about that being the highest, let's call it, incidence of complication in socket shield, around 9% from the 128 case paper that he presented. But again, you can see, that was managed. That was managed, without an issue. And if you look at, maybe we corrected it just a small amount. But yeah, absolutely. Again, in critically analyzing again, would I have probably done a thicker graft? Yeah. But still, still a nice
Beautiful.
result. And there we have happy patient. All right, last case.
Mhm.
Let's wrap it up here. So, you know, all the talk now is about essentially, let me turn my sound off for 1 second here. Can you still hear me?
Yeah.
You know, all the talk now is, you know, about facial scanning and merging it with, you know, with CBCT. And, you know, this is an image off of my cone beam machine, my RayScan R2 Studio that we're able to utilize. But, you know, many of the smile designer, the facial aesthetic folks will tell you that we still prefer 2D pictures to a, you know, to a certain degree. The technology is here. It's getting better and better. I think Bellis 3D just released a project with 3Shape, you know, so you can integrate both of those. So it's coming. But again, you know, or it's here. But again, you know, we have applications such as the DSD app that I use quite a bit by Coachman and Ralph, you know, Ralph George. And I will routinely, when I'm doing a case like this, is do the analysis with Smile Design. And again, as an oral surgeon, you know, doing Smile Design, you know, you can say, well, wow, what are you doing is hearsay. And, you know, but again, for me to learn Smile Design, to learn aesthetics, it allows me to improve my patient outcomes. And it allows, it's a communication tool with my referral docs, because I can talk, you know, we could speak the same language, and I can tell them why, you know, can I do this surgically? Can you do this restoratively? And, you know, in these cases, I get a lot of help from Dr. John Heimke out of Cleveland, who's oral design. And I think, Omid, you know John also, he's another expert on XP, but John is quite knowledgeable in this and, you know, helps me out quite a bit in these. So we use the app for, you know, before and after. And again, if you've used the app, when you do this, you can actually slide back and forth. And this is not gimmicky. This is actually, you know, if you look, you know, we're making measurements here. This is based on measurement, not just based on a Photoshop, but based on measurements within the, you know, within the smile frame. And you look down here and you have what's called Smile Donator. And what that is, you know, say, Omid, you know, you have a sister or brother who likes your smile and, you know, wants your smile, you can go ahead and scan and do, you know, copy paste dentistry, which is something that Christian, you know, speaks about quite a bit. You can mix shape, adjust shape. So this is not a Photoshop. This is a true, you know, analysis of the patient's smile. So we're going to take a look at that. And there. We're going to go ahead to the case. So this is a partial anodontia, root resorption. Just, you know, this young fella's been through quite a lot at 25 years old, and actually had a brother with quite similar, and his brother ended up, I believe, in some form of all on something. And, you know, so even at 25, his parents, you know, stepped in, and, you know, we were able to manage, you know, manage this case. But this is another case where we're going to say, well, what are we going to do here? What are we going to do? You know, primary teeth pegged. You know, you can see these canine centrals, canine, and there's actually some, again, resorptive process going on that, you know, I'm not showing you here. So again, you know, tough decision. And, you know, my concern is quite a bit of collapse here. What, you know, what are we going to do? So copy paste, go ahead and wax that in. See how that would look. Presentation to the patient. We're going to go ahead and plan the case. This is what I like to call my digital blueprint. So again, we're going to do implant, gap, or pontic, implant, implant, pontic, implant. Here's our wax up again. And every case the same way. plan, printed, analog position, and we're gonna mill out our provisionals. So here's our panoramic. And I don't have a lot to work with here. I really don't. And you know, you can say this is a bit of a controversial case. Everybody can have their ways of doing it. The tooth with the longest root here is the canine, but again, I've got major resorptive process going on here. You look at the mandible, some short roots, and you know the patient's been through quite a bit of orthodontics. So what am I going to do? Well, I'm going to go against some of the principles of socket shield because I've got very short roots here, probably maybe 6 millimeters max that I have to work with, a very narrow alveolus. I should have put a cotton roll underneath this lip here, but we can still get a soft tissue profile. But my thoughts were, what did I have to lose for this young man? What did I have to lose if we did socket shield on some short roots and see at least how long could we maintain, the PDL and the, and the bundle bone, so we planned the case digitally. And here we're going to go ahead and do the surgery. We're going to use 2 guides. Guide 1 is going to take through to the apex, which, as soon as I put the drill in, I'm essentially at the apex. And, Isaac spoke some on this with his, his innovative design, but this is one of the, the earlier routes of using a couple of guides to do this. So guide 1, shield apex, guide 2, implant path. Here we are. We've got these pontic hairs. This tooth is just really couldn't save this tooth to do a shield on it, but we'll, tissue graft and PRF graft that area. So there's our shields, implant placement. Okay. And as small as they are, we're going to maintain, and we're going to, graft underneath here. We'll show you that a little bit, a little bit later. Nova bone in the gap. There's our provisional post. And then we're putting in our provisionals and some PRF and a little bit of tissue under there that I'm not showing quite well. But again, some pouches, analog on our provisionals, little occlusal adjustment there. And what I also did on this case was I actually tacked these together to hold them in place from the palatal, from the palatal aspect. And again, this is where we were immediate post-op. So now we go to the next dimension. So before I spoke about, made to measure, and now we talk about versus bespoke. So a custom garment requires several fittings to feel natural on the body. And that's basically why I like to use a couple of different sets of, provisionals. We allow the surgical and prosthetic sites to heal in unison. We can remove the provisionals, refine those a little bit. But ultimately, when we're healed, we're going to rescan. We're going to do a second set of provisionals in these, in these cases. And this was a case, Omid, that I immediately loaded because, versus the other case where the teeth were kind of here and there, this young man had orthodontic correction. So the mandible was in a good alignment. And I had, a bit more of that first molar occlusion control here. So we're healed. And again, you look at this area right here. Again, I did not use tuberosity in this area. So kind of went against my principles a little bit. But again, we take that out and we're going to scan. We're going to put 4 scan bodies next to each other. I'm going to scan and see, see what we can do. So there's our trios file. And so, Omid, you know, you kind of jumped the gun on me a little bit, asking about the canine position, the number 6 position on that other case. So it's almost like I knew, you know, what you were going to do to me. So let's look at our alignment here. So, you know, really nice for you know, screw retention there. Okay, and you can see the position again. Same scenario: digital wax up, positioning, plan, and again, you know, with the technology, we can control each and every tooth. So you look at made to measure, that's like a stock provisional, whereas bespoke is custom from every step of the way, every measurement. You know, it's not like putting on a coat and then having the tailor take it in here and there. It's like having every placket when you do bespoke made on your body. Okay, so that's what I like to, you know, like to call it. Again, take out the provisional, and you'll see this kind of, you know, same scenario here, a little blood, a little red, you know, when you've had these immediate long-term, you know, long span provisionals, at least in my experience. And again, little Duralay pattern jig, and you take a look, you see if we follow the hole, fall right into the, you know, the central fossa cingulum area. So there we are. And all I've done here is put the new provisionals in, took them out, and you can, you know, you can see. And again, in a new long-term provisional. So a couple of weeks. So here, actually here you can see we leave this little gap here to allow the tissue to migrate down. This pontic area still looks good. And again, you know, we're still in the provisional phase. So I still have, you know, I still have flexibility in this case. Again, can I make this case a bit better? Of course, of course. I actually want to address this area a little bit right here, and like Michelle Azer, you know, said, I can use a little tunnel approach here to regraft this area. All we have is time. Like I said, I want this to be lifelong, you know, lasting for this young man, and we still have, you know, shield maintenance. You know, shield maintenance here. It did not lose any, you know, any implants or no implant related, you know, related complications. So I always like to end with this slide and tell folks, you know, the purpose of my lecture was not to show you my cases. It's really to provoke your mind to grow, to innovate, to think outside the mouth. We call it iPad living, and we're always inclusive. I've shown you many different cases, many different applications. And again, many of you do things this way, that way. But again, you know, we have an armamentarium of how we approach cases and how we customize, how we bespoke each and every one. So, Omid, having said that, here's my email if any of you want to reach out to me. And I always use this picture. Actually, this is almost in everything that I do, but it's a digitized photograph. I mean, that's, you know, a friend of mine did actually, one of the ladies from Versa, Osteodensification, did that to me, so do that for me. So thank you. And Omid, thank you so much for having me on. Greatly appreciated.
Thank you so much, Richard. I truly enjoyed your presentation, and thank you for going in depth of every case and showing us step by step. I truly believe that soft tissue shaping and soft tissue formation is, I think, the main key in implant dentistry, because we can do lots of bone grafting and successful one. We can do even soft tissue grafting. We can make prosthesis, but if we don't shape the tissue around the prosthesis, at the end of the day, the case cannot be that beautiful. So it's very important, and I truly enjoyed whatever you did and whatever you presented. I just have one question. Actually, it's kind of a question for me, but it's not a hot seat question. It's just for my understanding. In the process of making the provisional restoration, I noticed that you made, for example, Essex appliance. You also made another transition prosthesis like flipper. You had a fixed provisional. So you had many options for the patient. I want to know, imagine the patient come to you and you want to start doing the process. So at first, before extraction, you take an impression of the patient or you do the scanning of the patient, or you do it indirectly after extraction. First of all, I want to know more about that. What's your protocol in your patients?
Okay. All right. So what we do is I will see the patient for initial consult. Okay. And then we talk about options, what do we want to do? And then I have the patient back for what we call an impression and consent visit. Okay. So at that visit, what we call my digital assistant, one of my assistants been with me for 18 of my 19 years, and she knows me inside out. She scans pretty much all my patients. All my assistants have the ability to scan. I even have the ability to scan. All my assistants know how to scan. They know my scan protocol, intraoral scan. So we intraoral scan every patient, and we design ahead of time. And we talk about, I look at, is it a case that I can immediately provisionalize, or is it a case that I'm going to do an Essex for? And so we plan that ahead of time. And I will tell you, a lot of these cases that I am going to, or I want to immediately load, I will actually still have an Essex backup for the patient. There's been times when I've immediately provisionalized and, it'll loosen 2 or 3 times. And I'll say, you know what, this wasn't smart. I'll take it out and put them back into Essex. But that decision is made ahead of time. And again, we also scan them at every post-op visit. Do I sometimes scan during surgery? Yes, I used to do that a lot more, even back in the old days when we would place the implant and actually take an analog impression, take a fixture level impression, put a tray in at the same time, and then later on down the road, we'd have the provisional ready, ahead of time. But I kind of got away from that with digital technology because I could do a lot of my work ahead of time with the intraoral scanning. And then I also, the patient's a part of this also. I showed the case where the patient was going to Africa 3 weeks later, and that case I had planned to load it, but we ended up using the flipper, and I had options. So now that case kind of taught me, to ask my patients, where are you going to be in 8 weeks? What are you doing in 8 weeks? And sometimes my decision is made on that. It's not made on whether, what's the occlusion, can I do it? Sometimes it's made on the patient's lifestyle, because I've been burned a few times doing that, and I'll tell you, for some of my patients that travel quite a bit, I have some of these guys that are on the road 3 days a week, and they fly out on Monday, they come back on Thursdays. I have to treat them on Fridays, and some of those patients, as much as I would love to immediately temporize, I don't, and I've also developed a technique with my Essex where I can get fairly good maintenance of my margins and of my papilla with my technique. I think oh gosh, man, it's maybe 10 years ago, Omid, I have a presentation on XP about use of transitional partials. I mean, I think that's, if you search back, it's I think 10 years old on there.
And Richard, you showed one of the first videos that you showed about the importance of subgingival contour of the provisional and how you were uh, talking with your lab technician, I think, I don't know, or one of your assistants about how to form the subgingival contour, make it more concave, and providing more space for the soft tissue. I want to know that
Mhm.
at what period of time you did that scanning. I mean, after extraction, you did an intraoral scanning to scan the shape of the extraction socket and do the provisional on that, or before extraction, you did the scanning and you had the chance to have
Okay.
the shape of the subgingival area and make a provisional even before extraction.
Okay. That actually, yeah, you're actually asking me the same question again. Intraoral. Once I scan in my impression and consent visit, then that goes immediately. I click the button through 3Shape Communicate, and
Uh-huh.
that goes immediately to the lab. I've written some instructions in that digital prescription. Very important point. I've written some instructions in that digital prescription to please call me prior to design. So that's done. So then I go over to the lab, or I do a, now we can do Zoom or GoTos where we can screen share. I don't always have to go over there. We can screen share just like we're doing now. And I can say, hey, Jimmy, hey, Ralph, let's do this design. So that is done ahead of time. And again, one of the questions is, if I see a patient today and they want an implant tomorrow, can we do it? It really all depends on what time of day that patient I initially saw that patient. Because we usually need, about a 48-hour, lead time to do things the right way, to have, from when I see the patient to having, the provisionals milled out ahead of time. But everything is done ahead of time.
So you have
Nothing is done.
so you have 48 hours between your implant placement and delivery of the prosthesis, right? The provisionals.
No, 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 no. The prosthesis is delivered. So the prosthesis is designed and delivered to me ahead of time
Ahead of,
before surgery.
before surgery,
Yes,
before
before
extraction.
surgery. What I'm saying, yes, before extraction. But what I'm saying, at times when I'm in a crunch and say the patient says, well, I need this done in 48, I need 48 hours. I mean, yes, can I still old school immediately provisionalize at chairside? Yeah, I can still do that. I still have that analog, knowledge. I still have that in my toolkit. But from a digital standpoint, I probably need, 48 hours, because I'm not a big fan of placing the implant today and then coming back in a couple of days to immediately provisionalize. I'd like to get it all done, at that visit.
So, Richard, one of the other questions that I have, when we go through guided surgery, we are placing our implant through the guide, so the abutment is customized and the provisionals has been prepared according to the position of the implant. Is it possible to make a provisional restoration before starting the surgery, but placing our implant without guides? Do you find it possible? Is that's
Yes.
the question.
Yeah, it is, Omid. It actually is, because the way that you do that is, you design the about, you mean, so to make the provisional ahead of time? Yeah. So the way you can do that without doing it guided is you can still have your provisional milled out, because what you want to do is, like I said, whether it's socket shield or it's traditional immediate implant placement, in the maxilla, we know that our implant always goes towards the palate.
Yeah.
Okay.
Yeah.
So what you can do is you design for that opening in the crown to be more towards the palate. Then when you place your implant and you put your provisional post in, you can actually hollow out the internal aspects of that provisional a bit more to fit over. And that's one of the things that Moghaddas said in his paper. If you look at that, Moghaddas paper that I mentioned, that's, one of the things. You can always widen out or increase the internal diameter to slide over, to slide over that post. You can actually, to be honest with you, one of the things you can actually do is you can actually use a provisional crown as a guide. So if you have, let me go back here for 1 second here.
Because I really like the one of the slides that you show. It was really beautiful, demonstrated that how you shape the provisionals next together, and how you provided good space for the papilla between them. I think it's very important in multiple extraction cases, and I think those people, at least those who are starting to do such things, to take that into consideration, because if we plan at first way, we can be very predictable at the end of the procedure.
So if you look at this right here, okay, and if I take this this out right here, okay.
Yeah.
So if I take this and I extract the tooth and I put this in the patient's mouth, okay. So say this is the patient's mouth and I put this in, I can actually drill. I can hold this here and I can actually drill through this to guide my drill for the palate. Actually, that's nothing new. You can actually do that with the temp shell technique that I showed. The other case that I showed where it's like this here. If you look at this right here, okay, you can actually use this to place your implants. You seat it on the teeth, and this is not something I invented. This is, this may have first been shown in the DTX software from Nobel, and you just slide this over the teeth, and you can actually drill through that to place your implant. So you've already, if you want to do this temporary wise, this is another way to do it, and you can get this through several commercial labs. So you can actually use your provisional tooth as a surgical guide. And that goes in the whole same thing, Omid, in discussing, thinking outside the mouth.
Yeah.
I mean, when you're sitting here at your computer, when you're sitting here designing, thinking outside of the mouth. I think another one that you were, you were referencing, is
the multiple case in the anterior. It was really beautiful. Yeah, I think you showed the one under the Essex.
So like this.
Yeah.
Under the Essex.
Yeah, it was a slide. They were inside the Essex, and you showed the scalloping of the provisional.
Okay. Yeah. But even this case here, I'll go back to that one in a second. But even this case with the screw access holes already done here, you can, again, your placement may be a little off, so you can widen these holes to be able to drop over, as long as your implant is within that cingulum area for immediate. And the other case that you were referencing,
yes,
is this one right here.
Number 140. Yeah.
Yeah.
Beautiful.
Where, again, this is the importance of communicating with the lab about how, you want this designed, to get this effect. I mean, many of us underestimate the power of, transitional appliances.
Yeah.
There's a big load. But I've probably shown you just as many, delayed cases as I did immediate, but still with using, the digital technology. And I mean, again, the importance of, slides like this and like this. And again, this is where, and for the restorative docs out there, pros guys out there, I mean, this is when you communicate with the lab. You don't, I mean, especially for a long span prosthesis like this, I mean, you want to look at, I mean, I probably have 25 pictures of the design of this case, because we look at it in every aspect. We look at the buccal lingual, we look at each individual tooth, and that's why, like I said, this is one of my favorites. Also, I mean, this is just, this is just incredible, Omid. I mean, you look at this little toolbar over
Yeah.
here, and I mean, it's baffling what you can do with each tooth. And if you remember when I was working with Krista, and she had like the little wheel, and she was erasing little areas for me, and I was telling her, I mean, that's how detailed you can be. That's how detailed. I mean, overlays, copy paste. I mean, just I mean, this, if you take a look at this lower, I guess, lower right here, okay? So this implant may be a little bit deeper than this implant, so you'll see where I can extend down a little bit more sub G than over here. Bespoke, man. So.
Really good, really beautiful. I think it's something that it's something necessary, I think, for implant surgeons to stick to, because at the end of the day, we want to be predictable, we want to be reproducible in whatever treatment that we do. And I have to say, I'm truly honored, and I really appreciate that you gave us your time and your patience to give us this beautiful, comprehensive, step-by-step lecture. And me personally, I enjoyed it every second and really learned a lot. I'm pretty sure all the audience did. And what I have to say, I just want to say thank you so much, Richard, for your time. And again, officially, thank you for contribution to this book. It means a lot. And
Thank you, my friend.
We'll give you one very soon when I see you. And thank you so much again for accepting the invitation.
Been a pleasure. It's been a pleasure, and thank you for having me. And stay safe, man, and hope to see you soon.
See you soon, my friend. Thank you.
All right. Take care.